Hey guys, today we're going to review component alignment and total knee arthroplasty. There are several goals to every total knee replacement. The first is pain relief, followed by neutral mechanical alignment, balanced flexion and extension gaps, and a well-tracking patellofemoral joint. Before we can discuss how to obtain these goals, we first need to understand what mechanical alignment is. The mechanical axis of the lower extremity goes from the center of the femoral head to the center of the ankle and should pass through the middle of the knee. The goal of a mechanically aligned total knee is to have the bearing surface perpendicular to this axis. So let's start by reviewing the femoral axes. First, you have the mechanical axis, which goes from the center of the femoral head to the center of the knee. Then you have the anatomic axis, which is in line with the intramedullary canal of the femur. The difference between these two axes is 6 degrees. This will come into play as we use intramedullary referencing to cut our distal femur. The first thing you'll notice when you look at the tibia is that it's a straight bone, and the mechanical axis goes through the center of the medullary canal. This makes it in line with the anatomic axis, and the two can be thought of as the same. To set our coronal alignment, we turn to the distal femur. If you remember, the tibia is cut perpendicular to its mechanical and anatomic axes. Thus, the distal femoral cut determines the overall coronal alignment. This is done by using an intramedullary referencing device. First, an entry hole is made in the distal femur, approximately 1 centimeter anterior and slightly medial to the intercondylar notch. The starting point is also just anterior to the PCL origin and is in line with the medullary canal of the femur. With the reference rod inside the medullary canal, it is equal to the anatomic axis of the femur. Thus, in order to make a perpendicular cut to the mechanical axis, we need to cut the distal femur in 6 degrees of valgus. This measurement is variable, with taller people needing a less valgus angle and shorter people needing a more valgus angle to make it perpendicular to the mechanical axis. The depth of the distal femoral resection is typically 9 millimeters. This is equal to the implant thickness, thus you're removing 9 millimeters of bone and adding 9 millimeters of metal to the distal femur. Now we'll talk about making our proximal tibial cut. The depth of this resection is determined by using what's called a 2-10 guide. This allows you to measure 2 millimeters off the diseased side or 10 millimeters off the healthy side of the proximal tibia. When determining our coronal alignment, we'll take the alignment beam and center it over the tibial shaft. This should also be in line with the center of the talus and the second metatarsal, which now allows us to be perpendicular to the mechanical axis of the lower extremity. The last factor to be addressed with our proximal tibial resection is the amount of posterior tibial slope. Now this varies depending on if you're using a posterior stabilized or a cruciate retaining device. The reason being is that once the PCL is released, the flexion gap preferentially opens compared to the extension gap. Thus, if a posterior stabilized device is used, the tibia is cut in 0 degrees of slope. If a cruciate retaining device is being used, the proximal tibia is cut with more posterior slope, typically somewhere between 5 and 7 degrees. At this point, after cutting our distal femur and our proximal tibia, we can evaluate our extension gap. The extension gap is primarily determined by the distal femoral resection, since the proximal tibial resection is the same for both the extension and the flexion gaps. Assuming a rectangular extension gap, we'll now turn to femoral rotation. There are several axes on the distal femur that must be used to set the rotation. First is right size line, a vertical line connecting the deepest point of the trochlear groove to the intercondylar notch. Next, the transepicondylar axis, as the name implies, goes from the medial to the lateral epicondyle. This is perpendicular to right size line and parallel to the cut surface of the tibia. Finally, you have the posterior condylar axis, which is in 3 degrees of internal rotation as compared to the epicondylar axis. Our goal is to have the femoral component in line with the transepicondylar axis and perpendicular to right size line. It's at this time that we need to determine the size of our femoral component. Femoral component size is based on the AP diameter of the distal femur. One way of doing this is to use a posterior referencing system. This allows you to put paddles in the posterior aspect of the femur and measure the distance to the anterior femoral cortex. If you find yourself between sizes, it's important to use the larger size component, as the smaller component may lead to anterior femoral notching. Additionally, when using a posterior referencing system, it's important to remember that the posterior condyles are in 3 degrees of internal rotation. This means your jig must be set to 3 degrees of external rotation to make sure it's in line with the transepicondylar axis and perpendicular to right size line. Drill holes are made through this guide to allow acceptance of the 4-in-1 jig to complete the femoral resections. The 4-in-1 guide allows you to make your remaining femoral cuts. First your anterior, then posterior, anterior chamfer, and posterior chamfer resections. You can see with this animation that if a smaller component is chosen when you make your anterior femoral cut, this will result in notching of the anterior femoral cortex. The clinical relevance of this is debated. However, there is some literature to suggest that a 3 millimeter notch does have an increased risk of periprosthetic fracture. Now that all of our bony cuts are made, we can evaluate our flexion gaps. The flexion gap is made up primarily of the posterior femoral resection and the slope of the proximal tibial resection. Remember that the flexion gap must not only be rectangular, but also equal to the extension gap. For this reason, we choose a 9 mm posterior femoral resection. Lastly, we look at patellofemoral alignment. The goal here is to prevent an increase in the Q angle. Thus, the femur and tibial components are externally rotated and lateralized, and the patella is medialized. It's important to remember that when the patella is medialized, it is oftentimes everted, so do not confuse medial and lateral. The alignment of the tibial component should be centered over the medial third of the tibial tubercle. Additionally, you can use an alignment rod to make sure this falls in the center of the ankle and in line with the second metatarsal. Hope you've enjoyed this video and now have a better understanding of component alignment and total knee arthroplasty.